Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. The AASM released a new clinical practice guideline on the treatment of central sleep apnea. We reached out to some of the authors to help us understand how to put these guidelines in context. Here today are Dr. Rami Khayat, Dr. Shirine Allam, and Dr. Christine Wan. Dr. Khayat is Professor and Division Chief, Pulmonary, Allergy, and Critical Care Medicine Director at Penn State Health Sleep Services. Dr. Shirine Allam is a Professor of Medicine at Emory University and Program Director for the Pulmonary and Critical Care Fellowship. She practices at the Atlanta VA Medical Center. Dr. Christine Wan is Medical Director at Yale Centers for Sleep Medicine and Professor of Medicine in the section of Pulmonary, Critical Care, and Sleep Medicine at Yale University School of Medicine. They were all on the committee to create these guidelines and join us today to help us better understand how to implement these new treatment guidelines. Thanks for joining us today.
Happy to be here.
Thanks for having us.
Just excited to be here. Thank you.
So, Shirine, tell me about the process of coming up with these guidelines. So was this an AASM directive? Did this come from above?
Yes, the way I understand it is that it was an ASM initiative that, the guidelines, it was determined that the guidelines were ready. There's enough new evidence that the guidelines were ready to be updated. So that's my understanding, that it came from the decision to renew the central sleep apnea treatment guidelines came from the ASM.
And then remind us about the rules, because there's a certain way that these are done, right? So what are kind of the guidelines behind how to create a clinical practice guideline?
And I can jump in here, Seema. Not for knowing more, but having looked at this recently, I can say that, so there was a big need since 2012 for redoing the guidelines, and there's been some changes, as everyone knows, trials, implantable devices, things like that came out that clinicians really wanted an update. And as far as the process, the Academy has implemented this new methodology called GRADE, and that's an acronym for something like grading the evidence. And actually, it's very, very scripted and very rigorous and systematic. So most of it is you follow a process, and there's usually a methodologist and an expert in this process in the room to make sure the same approach applies to any guidelines that come from the Academy and other organizations. This is becoming now the standard of doing guidelines across the different specialties too. So many organizations use this approach. And it's basically, the way to think about it is it's evidence-based medicine where, randomized controlled trials are graded at higher than observational trials, which have higher contribution and accuracy than, say, retrospective studies and so on.
So this isn't just expert opinion then, right? It sounds like this is very rigorous.
Not at all. This is not like what people think of guidelines. And I think we've had, the three of us and other committee members to talk to our colleagues about this, because say, you guys did this. It's not necessarily we did this. We were sort of riding on the bus and the bus was going in a direction. we weren't the drivers. We were just, sometimes there is room, obviously, for the expertise. And we had a very diverse group as far as skill sets and clinical experiences and backgrounds and all that contribute to interpreting some things. But as to being able to say, well, this study is more important than that study, we can't say that. That's already established by the characteristics of a certain study.
So, Shirine, is there anything else you would like people to know about how these guidelines were built?
Yeah, I want to add one thing to the grade methodology, but I think Rami explained it really well, that it's already a very structured process that we just had to follow. Looking back a little bit, I feel like where the task force contributed the most was really in the initial planning stages, where as a group of experts and clinicians, we just had to decide what were the critical and important outcomes that we will be considering when we're reviewing the literature and when we're evaluating the evidence. So that was really the largest of our, if you can say, quote unquote, expert opinion, is what are the critical and important outcomes that we need to consider when reviewing the evidence in patients with central sleep apnea, and that we had also to ensure, according to the grade methodology, that all these outcomes were actually patient-centered and not just something that we think is important, but something that will actually be important to the patient population that we're treating.
So a lot of work up front then.
Yeah, absolutely.
So how did you decide then? Like, how did you decide who goes into what category? Tell me about that.
Well, I'll let others chime in too, but it was, we had an in-person meeting for this. So it was one of the big planning meetings for these guidelines. And we just had to kind of debate back and forth, like what's important when I'm treating somebody with central sleep apnea. If I'm looking at a treatment option, what are the things that I take into consideration before I apply this treatment to a patient, and what would my patient ask or expect when I'm treating them? So this is how we came up with the important and critical outcomes.
So Christine, was this something that was contentious, or did everyone pretty much agree?
Yeah, that's a great question. I think we were all coming from different backgrounds and experience, as Rami said, but I think we all kind of shared the same sentiment that this was long overdue. There was a lot of confusion about central sleep apnea. First of all, it's a heterogeneous disease. We presume there's a common shared mechanism, but it's associated with so many various conditions, in the heart failure group, the opioid group, primary central sleep apnea. It was just a heterogeneous population. So we, as Shirine mentioned, we just had to really organize our thoughts and decide how to approach this, or really tackle this treatment guidelines in such a heterogeneous population. It wasn't contentious, but it was a lot of work, I would say. A lot of smart people in the room often leads to a lot of discussion. And sometimes, you deal with a little bit of chaos before you get organized. So that was sort of our process, chaos before the organization.
Leading to organized chaos.
Yeah, organized chaos. There you go.
So is it okay if we kind of go through the guidelines step by step?
Seema, I was gonna just throw in a couple things for the clinicians to know that that these guidelines, any other guidelines that came from the academy, kind of start off by soliciting input also from patient groups, patient advocates, clinicians, and other professional organizations like cardiology, heart failure, people who have some stake in the disease process, third-party payers. I would say we didn't necessarily get the same level of input from everyone, but those also helped us frame the questions and how the groups were divided. And then eventually, as you know, the guidelines get put out there for public comment for a period of time too. So it's not just the group's input that influenced this so much as the process, the literature, the group's input, and all these opportunities for external comments and incorporation of these inputs.
Yeah, I mean, I bet third-party payers have opinions too.
Oh, yes.
And so that's interesting. So are they part of the early discussion, or is it once it's put out there and then they have comments and you go back?
I mean, it's both. We reach out to what you would call stakeholders, and we're calling them third-party payers, but they're sort of stakeholders. They're involved in coverage decisions. Some people choose, they have a policy of not being involved, which is good. Some people may just want to say, we'll look at the final product, things. So, but the opportunity was given, basically.
Oh, it was. Oh, that's nice. Okay.
And I would say we had left it for, we had put it out for about 4 weeks, I think, for public opinion. And I think it was at that point we saw a lot of input from the payers and the manufacturers, the companies that might have some stake in what they were observing. I would say we also solicited support from other professional societies as well. So, we really, to Rami's point, tried to make this a really all-encompassing, interactive product.
I love that you did reach out to other clinical groups too.
And Seema, can I add just one more
Yes,
thing
of
before we
course.
go into the... So one other thing that I think is important for people to know is that when we were considering how to um, come up with these guidelines, we started with the different types of central sleep apnea, like per the ICSD classification. And then at some point, we made the decision to group all these central sleep apnea subtypes
Yeah.
together when we're reviewing the evidence. And I get a lot of questions about that, and I think it may have generated a lot of questions or from the public or from the clinicians who are reading these guidelines. And I think I want to just take a couple minutes just to justify the reasoning behind this. And it was basically threefold. The first reason is that we thought most forms of central sleep apnea, maybe with the exception of opioid-induced central sleep apnea, really share kind of a common pathophysiologic mechanism with ventilatory instability, high loop gain. So that means that all the treatments are often acting on that similar pathophysiologic pathway. So all treatments are aiming to stabilize breathing and reduce loop gain. And then the second reason is that central sleep apnea, as we all know, is really rare or much less common than obstructive sleep apnea. And the research is very sparse. So many studies included mixed populations of central sleep apnea without really strictly adhering to the ICSD classification. So it would have been very difficult to separate by CSA subtype, number one. And if we had done that, we determined that we would have been there would have been really too few studies per category to make any kind of meaningful recommendations. And so our goal was really to provide clinically useful recommendations despite this knowledge gap. So that's why we grouped by treatment subtype as opposed to by central sleep apnea subtypes. So to allow us to kind of synthesize the evidence and apply that grade methodology kind of consistently across treatment types. But we also noted when there were safety and efficacy kind of nuances, and that was especially true for patients with heart failure, and maybe more so with heart failure with a reduced ejection fraction, if that makes sense.
And I would also add that, a lot of the studies that we ended up looking at, actually the vast majority of studies didn't differentiate the categories of CSA either. So that was a little bit of a problem as well that, I think led us to kind of think about it in this way.
Rami, thoughts?
Yep, nothing to add.
So can we go
Totally
through
agree.
them? So I like your preemptive strike where you're already you're foreshadowing, you're warning us about what some of these are. So the first one, and I'm just going to read this straight out of the guidelines, and then maybe y'all can help me understand this better. So the AASM suggests using continuous positive airway pressure over no continuous positive airway pressure in adults with central sleep apnea due to the following etiologies: primary central sleep apnea due to heart failure. So the heart failure group is in this one, right?
Mm-hmm.
CSA due to medication or substance use, treatment-emergent central sleep apnea, and CSA due to a medical condition or disorder. And so this was a conditional recommendation, low certainty of evidence. So basically, CPAP over no CPAP. Let's talk about this.
Yeah, so the comparison group was always no CPAP because again you're limited by what the literature has. So you're able to evaluate what's out there. So it's possible that CPAP is the best treatment or the worst treatment, but say it didn't get compared to other things. There are some limited comparisons, but the most common comparison was treating with CPAP or not treating with CPAP. And a quick kind of comment on the what's called low certainty of evidence and conditional recommendation. These are probably some of the weakest recommendations we can make, but and part of the struggle that Christine and Shirine and the other committee members were talking about is we really had to come up with something because clinicians rely on us to tell them, okay, what do you want me to do here, kind of
Right.
thing. So we were able to say, okay, it's better than not, kind of thing. And these are the disease categories where there was evidence for some studies. So the reason things are lumped up, and it is so wonderful hearing you, Seema, kind of taking them out of the box and looking at them one by one. But we had to put them in the same, in these buckets, because if you look at something like primary central sleep apnea, you just don't find much in the literature. So wherever we could lump a treatment modality for that was done for different types of central sleep apnea, we could increase the number of observations, if you will, and improves a little bit the level of recommendations, so we can come up with something meaningful and useful for the clinician.
So why is this? So it's conditional and low certainty of evidence. So how should I interpret that?
It is probably how it sounds. I think for a clinician to look at, I mean, there are some, nuance to, intermediate certainty and high certainty. And I think most people who, are familiar now with the vernacular of the evidence-based medicine is you really have to do this, or you probably should do this. This one is like, yeah, you may want to do this. This is kind of how you should think of it. It's harm and benefit balance is probably a little tilted towards the benefit, but not a lot. So that's kind of how it should be interpreted. Now, sometimes the lack of evidence shouldn't be, interpreted as evidence for the opposite. That is, like some things haven't been looked at. But in the area of CPAP, we had quite a bit of studies and heart failure and other things. So there has been a preponderance of evidence that, it's helping with sometimes with the AHI, sometimes with, other parameters that are important. So when it works, it works. So, and it's the other thing that I think, Shireen was referring to is our contribution is when we look at the therapy, we would say that, okay, this is probably easy to do and we know it's safe. And also, so that goes into this conditional recommendation category. So it's easy to do it. It's safe for the patient. There is some evidence of benefit. So, but the evidence is low certainty. We can't be very sure. So if you're like before a judge here or something, it's not like you were told that you really have to do this. This is like, yeah, you could do this.
Yeah, I think that, what we were limited by in terms of that the certainty was, really the studies out there aren't robust for CSA, and they're not long term. And unlike OSA, I think, one of our critical outcomes was how sort of symptomatic benefit, again, to Shireen's point, we really prioritize patient-centered outcomes, and daytime sleepiness was one of them. And we know that CPAP really helps daytime sleepiness in OSA, but I think the literature wasn't as robust in CSA, and I think that's where you get sort of that uncertainty of the evidence.
Okay, that's helpful. That's helpful. I like the idea of this is what we think the data is showing us, and a little bit of guidance for what to do, right? Because it always comes back to that informed conversation with your patient. And I wonder if this then will help us inform with the patient saying, okay, well, we can try it, but, let's be realistic about, and is it, timed trial? I don't know what that looks like, but I think it would at least inform the conversation with patients.
Yeah, absolutely. And I think because without, more robust sort of long-term data in terms of cardiac outcomes in the heart failure patients, things like that, we're really focused on patient symptomology.
Yeah.
I mean, we have good evidence that it reasonable evidence, I should say, that it does reduce the central apnea burden.
Sure.
CPAP does, but in some individuals. But I think, what we really want to emphasize was, does that translate into clinically meaningful outcomes?
Yeah, and I think that's really important, right? It's not just about fixing the AHI and making the download look really pretty.
Yeah, absolutely. And we actually struggled with that in the beginning. And thank goodness for ASM and the methodologists there, because I think we all got initially when we started doing this guideline, we sort of were thinking about what are the most effective, in other words, the effective therapies that reduce AHI. And, thankfully, people who are experts in the grade process, part of this committee was really, steering us to, hey, guys, pay attention to patient-centered outcomes. And, these are the critical outcomes that you want to evaluate for these guidelines.
Oh, I love that, actually. I love that because you're right. We get so focused on the AHI. So I love taking that step back. All right. Should we tackle a second one? So I'm going to read this out. The AASM suggests using bilevel positive airway pressure with a backup rate over no bilevel PAP with a backup rate in adults with central sleep apnea due to, so this is primary CSA, CSA due to medications, treatment-emergent CSA, CSA due to a medical condition or disorder. This one is a conditional recommendation, very low certainty of evidence. Shirine, talk to me about this one. Why the backup rate?
We can take a step back to say, I don't know if you want to do it now, but there was a recommendation against the no backup rate, right? And that's because from a pathophysiologic perspective, we all know, and we've all seen it in our sleep labs, that BPAP augments ventilation and can actually induce central sleep apnea, right? So it doesn't make sense to treat central sleep apnea with BPAP without a backup rate. But introducing the backup rate can help you treat those central sleep apnea events when they're arising, and therefore improving the subsequent hypoxemia that happens and possibly the arousals, right? So that's why the backup rate is there. You do notice that two things in this specific recommendation. One is that the certainty goes from low to very low, and that's primarily driven by the number of studies that were available for BPAP with a backup rate. So there were like maybe barely 6 RCTs, and the number of patients total were just a few dozens maybe. So the overall number of patients, as opposed to CPAP where there were 200 to 300, maybe a little bit over 300. For this, the maybe 128 for the AHI, looking at the AHI outcome, there were 128 patients, but all of the other outcomes, there were 30s, 40s, right? So that's why the very low certainty, because there's much less data out there on BPAP ST. And the second thing that you notice is that we did not include
heart failure.
CSA due to heart failure.
I did notice that. I'm curious about that. Why isn't that in there?
So I can tell you why I think it's not in there. And if maybe Christine and Rami have a different interpretation, it could be something interesting to discuss. But from my standpoint, again, there was very, when we looked at data, we had placed a strong emphasis, because we lumped all the CSA subtypes together. We needed to place a strong emphasis on safety, especially for this most vulnerable population, which is patients with heart failure. So when we looked at the data for the BPAP with a backup rate, there were definitely, clinically significant improvements in polysomnographic indices, AHI, CAI, reduction in arousals, and a small study even improvement in left ventricular ejection fraction. However, none of these studies really reported any kind of safety outcome. There was no mortality, there was no hospitalization, there was none of that. And so in patients with heart failure, when we already have safety concerns from the SERVE-HF study, as we all know, where it was hypothesized that the ASV used in the SERVE-HF study caused harm, maybe because of hyperventilation and increased intrathoracic pressures. We don't know why, but that's one of the hypotheses. then I don't know that I can justify using BPAP-ST, which is really designed to augment ventilation.
Right.
And if you titrate it, to eliminate central apneas in the lab, you can definitely easily, end up with IPAPs that are pretty high, right? Or pressure supports that are pretty high to overcome the central apnea. So it's hard for me to justify that without any kind of safety data for BPAP-ST, that I would say it's okay to use BPAP-ST with patients with heart failure. That's my take.
Christine, what are your thoughts?
Yeah, I mean, I think this was probably one of the hardest points or recommendations to get through for many of the things that Shirine brought up. The lack of evidence was the primary reason for sort of the difficulty in addressing the situation, right? If we had great, robust evidence, even, any kind of evidence, really, we probably could have made more sense of it. But without that evidence, I agree with Shirine. We had to think about it sort of from an expert opinion, if you will, way. Sort of also inferencing from other studies, other modalities, and again coming to a consensus within the group what we thought. And I agree with Shireen that the lack of harm data was sort of striking, and again because of sort of this population with that SERVE-HF trial showing mortality, we really took it a cautious step in the approach to this BiPAP-ST without a backup rate, or with a backup rate. I'm sorry.
So, but the next one is the AASM suggests against the use of bilevel positive airway pressure without a backup rate in adults with CSA primary CSA due to heart failure. So heart failure is in this group, CSA due to medication or substance use, treatment-emergent CSA, CSA due to a medical condition. And this one is conditional recommendation, very low certainty of evidence. And the thing that I have really been struggling is, I mean, I hear what you're saying about hyperventilation. Like, I hear you, but what about like low pressure support, like low BPAP without a rate? Like, that's the part. I mean, I get what you're saying, that you create, like in the lab, right? That's how you use it to create instability, ventilatory instability. Like, I totally get that. But isn't a pressure support of 8 so much different than a pressure support of like 3 or 4?
You're absolutely right. And I think that was our intention, to be to make that nuance notable in our recommendation, because we did reference that, the study with the BiPAP without a backup rate, the parameters for that BiPAP setting that treated the central sleep apnea was really small pressure support, working really more like a CPAP than a BiPAP.
Yeah, that's fair.
So we didn't want to get into, this is a BiPAP machine and this is what you can or cannot use for central sleep apnea, but really thinking about the modality that it was in. And we looked at that study. It was one randomized controlled trial, and we really thought that the way the researchers were using the bilevel on that study was really equivalent to a CPAP. So based on that, we really couldn't make a recommendation for BiPAP without a backup rate. And so we resorted sort of to the more physiology, sort of the mechanistic reasoning for this recommendation.
But you know
I
what?
know this is a stumper, yeah.
No, but what a lovely way to describe it. Because you are then lumping in low pressure support bilevel PAP, acting more like CPAP, which would fall under the first recommendation.
Right. And that's what we hope to convey.
I've read these a lot, and I didn't get that, so I really appreciate you. I really appreciate you clarifying that for me.
Right, because when you give someone a BiPAP machine, you're assuming that they need this BiPAP machine, at least for central sleep apnea, for ventilatory support, and that's not really what we want them to aim for when they get a BiPAP. Maybe, yes, for a little bit of comfort, for expiration, just like we use for people who are CPAP intolerant in OSA, but not really for ventilatory support, which is sort of the assumption when you give someone a BiPAP.
That's fair. Okay, that's fair. That makes it make a lot more sense because, boy, I had a lot of questions when I first read. I think I was bugging Rami about it earlier too because I just didn't get it. So, Rami, I
Yeah,
know you
but
have
this is
thoughts on
great
this.
how you kind of put it to the test. So it's helpful for us to process how we will talk to our colleagues too. But we are limited with what we can say because once you go into this framework of evidence-based and grade approach, you can use terms like low certainty, high certainty, very
Yeah.
low certainty, conditional, non-conditional, things like. But we can't just say pressure support of 3 is different from pressure support of 4 or 5. And that in itself too, I want to just to clarify this too, is if you're talking about a very thin, older or younger patient, I mean, pressure support of 4 may go a long way in
Yeah.
ventilating someone. So it's really hard to put a number on it. And this will, you will see a theme that emerges from all this. We're trying to tell our colleagues that please be careful with this. All these devices that ventilate patients, you really have to monitor and know what you're doing with
Yeah.
them. So, but it is true that as we all know that there is some degree of pressure support in the modern CPAP devices. And that's also variable because it impacts certain portions of the respiratory cycle, not all of it. So it can't be necessarily called pressure support, but it can be, called like pressure relief or something like that. But it does function in the same way. And I don't think anyone can argue that pressure support of 2 or 3 is really pressure support on a
Mm-hmm.
BiPAP machine. It's just, maybe just expiratory relief of some sort.
Mm-hmm.
But we just don't know what that threshold is, and the point is we just don't want people to feel comfortable doing 5 and 6 and 7 without looking at the impact on the tidal volume and the ventilation of the patient.
Well, I love it. That's a very thoughtful conversation about how it's not just like a line in the sand. It's, is this setting creating more ventilation than we maybe need? Yeah, I like that. So let's take a short break. And when we come back, we'll talk more about the updated AASM clinical practice guidelines for the treatment of central sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Khayat, Dr. Allam, and Dr. Wan about the new clinical practice guidelines for the treatment of central sleep apnea. All right, let's get to the big one. So the next one is the AASM suggests using adaptive servoventilation over no adaptive servoventilation in adults with CSA due to primary CSA, CSA due to heart failure, CSA due to medication or substance use, treatment-emergent CSA, and CSA due to a medical condition or disorder. And I do like that you guys put in this remark. So prior to the initiation of adaptive servoventilation, patient-provider shared decision-making is recommended, and treatment decisions should be based on expectations of symptomatic or quality of life improvement. Treatment with adaptive servoventilation in patients with heart failure with reduced ejection fraction should be limited to centers with experience, along with close monitoring and follow-up. So, Rami, this is what you were kind of talking about with the close monitoring.
Yes. And, in a sense, this is kind of an extension of this process, but obviously this is a very loaded topic because it did trigger a lot of questions and there was a lot of controversy. As you know, we've been telling people ASV is bad for heart failure patients, and it looks like as if we're saying it's good now or something like that, which is not exactly what we're saying. We're just saying it's not bad anymore, which is a little different.
So, but that's an important distinction, right?
Yeah.
Because things have changed.
Yeah.
Right? The algorithms have changed, the machines have changed, and then Imran did that study, that meta-analysis looking at this question. So talk to me more about this.
Yeah, so I mean, in the big picture, there was the SERV-HF used this one type of machine with one type of algorithm and as a very specific setting. And, everyone knows that it showed harm or it found harm rather than it showed harm, because it wasn't designed to look for harm, was designed to do one-way testing, but it did stumble upon some harm that was not explained. It had never been an explanation. We still speculate, well,
Yeah.
it's the pressure, it's the ventilation, it didn't treat the obstructive component. We just don't know what happened in it. Years have gone by and we haven't had an explanation. But what we know is in order to prove that a device like this increases mortality, you really have to be looking, as Imran and as our analysis in this in the meta-analysis that we did, you need about 4,000 patients in a randomized controlled trial designed to look at mortality. So no one has ever done that. And, the way we looked at it is we're somehow singling out this device that's actually very effective and very helpful to our patients and clinicians. And we're saying this is causing harm, but no one looked in the same way at any other device. So there is not even any trial of any size looking at BiPAP, ST or S or any other letter you want. So you can't really use different scales even for looking at devices. So what we were able to conclude from putting all the randomized control trials in SERVE and the Advent HF, to say there is no class effect. ASV in itself wasn't a harmful treatment, but we couldn't say, for example, that it's beneficial treatment. But again, by the same token, in a sense, ASV doesn't extend your life, CPAP doesn't extend your life. And that's why we wanted to say, okay, it's another tool available to the clinician. It's okay to use it, but you have to be really careful. The patient needs to know you're not using it because it may extend their life or treat their heart failure or do any of this. It may improve them symptomatically. And if you decided to use it, you have to be really aware of all the nuances of using a device, complex device like ASV. You have to be able to review the download, to analyze it, to make adjustments on it, to make sure the patient isn't being overventilated or undertreated or overtreated. Be able to look at ventilatory parameters like, bicarb, like, oxygenation. Make sure their cardiac status is doing well. Make sure that they have guideline-directed therapy and all that. So, but that applies really to any treatment with central sleep apnea. I can say a couple more things, but I want to make sure you don't have a follow-up here, Seema or Christine or Shirine on this.
I'm sure Shireen has thoughts.
I mostly agree with what Rami is saying, really. Like, we followed the process of the grade methodology to take another look at the safety signals in ASV. And we included the SERVE-HF, even though that device used in the SERVE-HF study is not on the market anymore. It was included in the hospitalizations and mortality safety evaluations, or in the systematic review. And there was no statistically significant signal that the ASV modality is harmful. So we had to conclude that it was not harmful, and consistent with the CPAP and BPAP ST, it does improve PSG indices. There is some evidence that it may improve Epworth Sleepiness Score and arousal indices. So we conditionally suggest that, it can be used in patients with central sleep apnea.
Can I push back a little bit?
Sure.
So I like the remark about the shared decision making, but when you're treating people with HFrEF, that it should be limited to centers with experience along with close monitoring and follow-up. I know that's just not really an option for where I live. And so I hear that. I appreciate that. If I had a center, yeah, I would love to send them there. But guide me on, so I've heard you say make sure you're not hyperventilating, right? I think one of the issues was undertreating the OSA, right? And so if we're choosing to use ASV in a patient with central sleep apnea, HFrEF, these are the things that I should be mindful of, right? And then follow them up closely.
So Seema, I don't think you're not a center. I think anywhere you are, there would be a center around you. So, and I think if the clinician is comfortable
Yeah.
with this, and there is no reason why, a board certified eligible sleep physician would be comfortable. But what we know also, some people aren't comfortable with it. And I think you have, this allows people to decide, can you do this actually? If you're not comfortable doing it, then, please send the patient somewhere where a colleague is comfortable. So the requirement of a center, obviously, there is no certification or anything. It's a sleep center with experience,
Okay.
someone who says, I'm comfortable doing it. So it's incumbent upon us then to, if you're not comfortable, to become more comfortable.
Yeah.
And that's what we owe our patients. We can't, just like we're doing the, neurostimulation and all these things, or we're telling patients to do something, we have to be very comfortable with it and know its side effects. And also we have to consult the patient on these studies that, when we tell the patient, hey, there is some concern in this study, you may come across that. So I just want you to know the academy looked at it and didn't feel that this concern is justified. I'm going to put you on this device because it did help your central apnea very well. And we need to monitor together that you're continuing to benefit from it. You're actually realizing some benefit as far as your quality of life, or, you're feeling better with it. If it's not doing anything for you, I don't want you to be on it because, there's no point in that. I'm not going after numbers here. I'm going after
Yeah.
your symptoms. So we have to be able to consult the patient too. So that's why we should be comfortable with it.
Yeah, and I think that's fair because for me, I know our patients are really resistant to moving outside of our community. And that's, I think, is sort of a cultural thing here. And so I like how you said that this is, this is our goal of treatment. We can try this. Please know that there is a center 4 hours away and we can send you there. I mean, I think that just is part of that conversation.
You remember when you escalate to implantable treatments, for example? I mean, this is probably becoming a common theme as we're finding more complex, the disorder, obstructive central. Even if you were going to prescribe pharmacotherapy, like
Yeah.
GLP-1 or something, maybe you don't have it in your center, for instance, but it's FDA-approved therapy that you may want to offer it to the patient. So it's one of these, a combination of how comfortable we as sleep providers are, and what are the resources where we're practicing.
And I think in the spirit of guidelines are meant to be guidelines and not handcuffs, right? So I think that's well taken too. Your point is well taken. So let's go to the next one. The AASM suggests using low flow oxygen over no low flow oxygen in adults with CSA due to heart failure. So this is a conditional recommendation, low certainty of evidence. Let's talk about this one. Christine, what are your thoughts?
I think this recommendation sort of parallels what, at least in our gathering of the evidence, sort of parallels what was happening with the CPAP. There were several trials looking at the use of oxygen, and it may improve parameters, may or may not improve symptoms. And so just again, along with the evidence, we went with, a conditional recommendation for. We didn't see potential harm. We didn't see inequity. We didn't see any huge burdens of cost. So that's where this recommendation landed. But I think, again, with any of these recommendations, I do think, consideration of sort of the individual. And, we're not recommending, what to try first either. So I think this, in the context of everything else, we're talking about the different PAP devices, patient adherence and tolerance. These things are important as well.
But what a good point, because I think intuitively, I would have thought that the first guideline is the first thing you should try. But you're saying, no, this is not a treatment algorithm.
Yeah, we really didn't offer a treatment
Mm,
algorithm. This guideline was not meant to do that, although in our feedback from the reviewers or the public reviewing, a lot of people wanted that, but
Yeah.
we this was not meant to do that. It's to provide an algorithm.
So there is a remark with the oxygen one. Patients with transient and mild CSA symptoms at high altitude may reasonably decline treatment with low flow oxygen.
Yeah, and that's because we know that, high altitude central sleep apnea happens to everyone, healthy
Right.
people, at a certain altitude. It's physiologic. It's, people can be very symptomatic, but it's a transient phenomenon. A lot of people acclimate over time and it goes away after a few days perhaps, or people descend. So the use of oxygen in that instance, there might be evidence that it might help. And so if that's important to you for the day or two or few days that you're up in high altitude, then, we support that. But we didn't feel it was a necessary recommendation, or that at least the evidence didn't point that it helped in terms of important outcomes like, preventing pulmonary edema or cerebral edema, any kinds of that. So we didn't make the clinical meaningful outcomes weren't there. So it was more driven by symptomology and the sleep.
So do they have to be hypoxic then?
That's a good question. We thought that, we think that central sleep apnea and high altitude results from hypoxemia. The sort of hyperventilation that the hypoxemia altitude causes is going to cause us to be hypocapnic, and that might be the driving mechanism for central sleep apnea. So yeah, there is the inference that there is a level of hypoxemia at these hyperbaric settings.
What about for people who are at home, they're not at altitude, and they have CSA and intolerant to PAP or what have you, and that we would like to initiate supplemental oxygen? How do you go about getting that approved? So I'm assuming they have to be hypoxic, or can you do it just for CSA? Like if you have central sleep apnea and you're not hypoxic, like how do you get it?
Yeah, I think that's a good point. And, we have to distinguish too between a therapy that, works, but not covered. And I think we as clinicians, need to know about these things because maybe our patient will pay for oxygen. I mean, in fact, when you think about it, if it's a transient usage in high altitude and someone rented the oxygen for, I don't know, a few days, they and you felt it's appropriate, just give them prescription and they'll do it or not.
Yeah.
So there may be other ways, but we do have to distinguish if something is, because we don't want to just, this is where the third party payer is not as important as our patient or the
Right.
evidence.
Right.
But that being said, I think to your point, Seema and Christina, I don't know that insurance will cover like CMS will cover oxygen if you don't have the 5 minute in this criteria for CMS. But a lot of central apnea patients will meet that, and some won't. And that occasional patient who oxygen is their only option. For example, you brought him into the lab and you actually demonstrated some benefit in it and all that. I mean, you would have to navigate sort of with your patient how to get it covered, or they can't pay for something, or if you're really convinced that was like a good option actually for them, maybe you can get them, to use it for 2-3 months and see, and then decide that they benefited or not. So there may be some nuanced approaches to this, but
Well, because
probably
I feel like Shirine has an advantage here that she's at the VA.
Yes. So for central sleep apnea, I think for just nocturnal oxygen, it's probably much easier for me to get it at the VA than it is if I wasn't in this setting. So I have never had any issues prescribing nocturnal oxygen for somebody based on an overnight sleep study, whether it's for, hypoxemia or whether it's for, central sleep apnea. But I would say that it is important to actually do this sleep study and document that, what you're trying to treat actually did improve with oxygen, and then prescribe oxygen. But yes, I do have that advantage. So
If it makes you feel better, Seema, my understanding is at the VA, they have access to oxygen, but not to a sleep lab. I don't know about
Come on.
Shirine, but our
That's
patients
nuts.
do wait very long to get in. So.
Your meetings must have been a lot of fun.
Yes, very much so.
And Christine, I'm sorry, I totally messed that up because I skipped ahead. The remark was actually for the next recommendation. So the first recommendation that we were meant to be talking about is just CSA due to heart failure. And then the next recommendation is ASM suggests using low flow oxygen over no low flow oxygen in adults with CSA due to high altitude. This is where the remark is. Patients with transient and mild symptoms, CSA symptoms at high altitude, may reasonably decline treatment with low flow oxygen. So my bad. I put those together by accident.
No problem. And thank you, Shirine and Rami, for saving me.
I love it. We're all humans. I think we demonstrate that like every single day. I'm really excited about this next one. So the AASM suggests using oral acetazolamide over no acetazolamide in adults with CSA due to the following etiologies: primary CSA, CSA due to heart failure, CSA due to medication or substance use, treatment-emergent CSA, and CSA due to a medical condition or disorder. Conditional recommendation, low certainty of evidence. Let's talk about acetazolamide. And I was kind of surprised, that I don't know. I haven't used it, and I'm trying to become braver, and I would like to think, be really thoughtful about the patient that I would consider using this in. I'm not there yet, so I'm hoping to learn from you guys.
Yeah, and this is one that, I don't think anyone has actually used it enough but, when I have minimal experience in it, and maybe like I will use it or have a patient who someone put them on it, maybe every year or so. And I see a lot of central apnea actually. But that being said, like you said, I'm also trying to be more brave and, you grab it and use it sometimes. It's fine. But some of our colleagues, when we run into them in meetings, are more of a frequent user than than others. So and the experience with it is okay. That being said, that didn't weigh on the guidelines. Obviously, this is just based on the few 3 RCTs I think there were, and were generally short-term studies. So I'm actually really surprised when once we put this one in the machine came out as even a recommendation for. But part of it, what's hidden in this too, is the duration of follow-up sometimes. Nothing really followed up patients for several years, for example, much less, most of the studies do it for a few weeks. So acetazolamide trials were short-term, but generally, showed some efficacy. And I think there are a couple more coming down the pipe soon with similar agents. I don't know what the status is on that. So it seems like there's some interest in it. And I think we should be, it should be available. We should give it a try in central sleep apnea patients, especially if they didn't tolerate the device or as part of a, multi-modality approach like oxygen plus acetazolamide, CPAP plus, or something like that. There's no downside to a trial of it.
Well, the one that kind of surprised me is that the next suggestion is CSA due to high altitude, and it was pulled out as a separate recommendation. And I think it's because it was very low certainty of evidence compared to the other one that was low certainty of evidence. And this one really surprised me because I remember as a pulmonary fellow, we talked about this all the time. Somebody's going to altitude, give them some acetazolamide. And I get it's not always for CSA, like I get that. But this one surprised me.
Yeah, I wouldn't be disappointed in the very low and low, when you're out there with very little evidence, it just takes very little. But this one, again, it's just 2 RCTs and, there's not a lot out there, basically. We just wanted to point this out. And this is difficult too with the high altitude because an acute setting.
Yeah.
Patients, this one, I mean, I've sent people a prescription who are going to travel and they come back with mixed results. I don't know what the experience for you, Seema, Shirine or Christine, with the high altitude one, but, people say I didn't do much. Some people say, yeah, it helped. I don't know what, but it's very small trials.
Yeah.
Yeah, I think the evidence for either, the other CSA due to other conditions or a high altitude are both pretty limited. But I agree with you, Seema, when you say your impression was kind of shocking about the high altitude is because I think we more commonly see acetazolamide being used for, pulmonary edema, cerebral
Right.
edema, high altitude sickness. So other conditions that we readily give acetazolamide for. So I think we imply, well, maybe CSA is part of that that syndrome, and that's why we're so cavalier about giving it. But really, we were guided by the evidence, the research, and that's where it led us. So there really isn't that level of certainty for that use in high altitude CSA.
I think you're right. I think you said that really well, that we are lumping it in with the rest, the pulmonary edema and the headaches and the insomnia and all of that. I think you're right. That makes sense. Other thoughts on this one? So then the last one is the AASM suggests using transvenous phrenic nerve stimulation over no transvenous phrenic nerve stimulation in adults with CSI due to the following etiologies: primary CSA and CSA due to heart failure. And this was a conditional recommendation, very low certainty of evidence. And so the remark on this one is, given that transvenous phrenic nerve stimulation requires an invasive procedure, is not universally accessible, and is associated with high costs, it may be more appropriate to consider other treatments first. Rami, what are your thoughts?
Yeah, I mean, I thought this one was pretty, solid, but
Yeah.
this was, I mean, the main thing that affected this recommendation and kept it in the or very low certainty is the number of patients. There's only one trial. It's almost like somewhat unfair because it's a niche therapy that not everyone is a candidate for, but so there wasn't a high volume of patients in it, but the study was pretty, was positive and showed safety and included up to, I think right now, couple years follow-up on small number of patients. So people are becoming more and more comfortable with this as an option. And we want it available to our patients. And we were excited to put it in because, here's another thing that the clinician needs to know, that it's okay to think about and offer it to the patient. And now they see it in the guidelines, and then it's possible to incorporate it in your treatment approach. And yeah, we did, we were concerned, obviously, that it's an implant. But the field has become very comfortable with this approach now.
True.
With the, with the hypoglossal nerve stimulation and the other things that are coming also down the pike too in the area of neurostimulation, that we're becoming more comfortable with this, and our patients come asking for it. So it's good to have it here for sure.
So when we were chatting earlier, you mentioned that the treatment of central sleep apnea is changing, and it's now sort of under chronic disease management. And you kind of let this pearl slip about this billing code. So tell me about it. I think you said it was like G211.
Well, so I probably shouldn't be doing this
Okay.
on public, but there is because these aren't necessarily like ordained changes for central apnea. But what I was saying is, as a clinician who works in this area and have some experience in it, and I think the group agrees with that in general, and it comes across our guidelines that central sleep apnea is a chronic condition.
Yeah.
And there is actually a billing, like a modifier that people add. And I think I put it in to say that our clinicians should think about central sleep apnea in the same way you think about managing, diabetes or hypertension. It's a chronic condition. You need to see the patient regularly in close intervals and make sure that they're continuing to respond. Central sleep apnea is even more so than anything else, because it's both a disease and a physiologic response at the same time, and so many things can affect it.
Yeah.
Medications, weight, cardiac status, arrhythmia, whatever. So you really need to be seeing the patient at close intervals to make sure that they you cannot just forget, just give them the device and see them once a year. So I wanted to make sure that this comes through, at least, if mine and the groups, and I ask Shirine, Christine to comment too, but we felt really people should be followed up, especially with that most of them do have other chronic conditions. And yes, there is a billing code that they clinicians can use to help them get compensated for that extra follow-up and time, and I think that generates, like, I don't know, 0.2, 0.3 work RVUs in addition to the diagnosis.
Yeah, but that's important, right? I think that's how we ensure longevity of our field. Is it's not taking advantage, it's using a code that's existing for this purpose.
Oh yeah, I mean, imagine like managing central sleep apnea patient, and a follow-up is going to be, it's more time
Yeah.
consuming, and there's a
Yeah.
lot involved than anything else. In fact, you may even have to do time-based billing here, and may do other things too
Yeah.
to be able to, maintain, sustain your practice. I mean, it's getting very hard for people, for clinicians, and we have to look at ways to make it possible to do the right thing, without being penalized.
So let me ask you guys a question. This is something that has bothered me for years now. Is that, as we sort of have evolved as a field with diagnostics kind of chasing the AHI, and now we have a number of novel devices that don't distinguish between obstructive and central events. What are your thoughts on the direction that we're headed here?
I can just like one thought, and I know Christine and Shireen have some ideas too here, but if the number is zero and I'm comfortable that it's a true AHI, then maybe it doesn't matter to know at that point. But if the AHI is elevated, and if you're talking about diagnostic or confirming that the therapy is working,
Yeah.
but say like someone is on a therapy and I gave him one of these devices and the AHI comes back as 1 and the patient is, asymptomatic, I think I'm probably satisfied here. But if the AHI comes back as 10 or 15, or the patient
Mm-hmm.
has some symptoms, then I may want to know if it's central or obstructive in the context of me treating central sleep apnea.
And I wanted to add sort of to what you were discussing earlier, Rami, about the chronic CSA as being a chronic condition that we should carefully manage, and this following the AHI is that, unlike obstructive sleep apnea, perhaps, central sleep apnea can change in severity over the course of someone's medical care because, especially with heart failure, if you optimize the heart failure, or the patient decompensates with their heart failure, their AHI, their central AHI or their central sleep apnea could change. And so I think that we have to remember, and so that obviously requires more follow-up, a closer attention to these outputs of the devices for the residual AHIs. And even people with, on opioids, they could change their prescription doses,
Right.
or tolerance, add on, and new medications come up. So I think this all, supports what Rami was saying before, that central sleep apnea is a chronic disease that needs careful follow-up, and the importance of monitoring with these devices and the residual outputs.
I guess the thing that I was thinking about is that initial diagnosis, right? Because let's say you have somebody and you have a device that doesn't distinguish, like maybe it's a PPG-based device or something like that, and it just says unclassified apnea. And then you go down the road of CPAP and maybe it doesn't work well for the patient, or just I feel like it would be nice to know ahead of time, is this primarily central? Is this primarily obstructive? And so that's the granularity that I feel like we are losing with some of the newer tests, not all of them, but just with some of them.
Yeah, I agree with you. I think we are losing that granularity that's important in our treatment choices and our treatment algorithms because, yeah, an AHI, and not only just the AHI, but sort of, the characteristics of the sleep breathing disorder.
Right.
How long was it? How much hypoxic burden is there? Was it associated with sympathetic bursts? And, these kinds of nuances, I think, to all of us here who treat these patients day in, day out, are important in terms of outcomes and how we decide on what treatment modality to go for. So I agree with you. I think we're getting over. And I think this, interestingly, was what happened when we first started the guidelines is we were focused too much on the AHI, and then we all had to step back and say, hey, there's other things we have to consider. And same thing here, as you mentioned, Seema, these new diagnostic, as convenient as they are, just becoming oversimplified and too focused on the AHI, and that's not necessarily what we want.
Yeah, I agree. And I'm sure you've been getting a lot of questions from your colleagues about these guidelines. Have we hit on all of the questions that you've been receiving from your colleagues?
I think this was great, Seema, kind of going systematically, through them. And just a quick comment, point you made about at least knowing that the type of the sleep disorder breathing or the breakdown of AHI at baseline is important, becoming increasingly important too as you're considering therapies. So, for example, if you couldn't distinguish and then you recommended hypoglossal nerve
Right.
stimulation and it didn't work, and then they actually turned out to have some central events at baseline, or vice versa, you're considering for an implant. So at a minimum, I think initially we really should have a very good profiling of the patients, like Christine said, not just the AHI, but good maybe PSG impact on arousal index, hypoxia burden, and however we interpret that to be, symptomatic burden, all that, and then the decision making and the treatment options come, so that some of these devices that don't distinguish maybe just should mostly be used for screening, or maybe to test the efficacy of ongoing therapy.
Oh, that's an interesting thought. Yeah. Yeah. Shireen, your thoughts?
Yeah, and I don't have much to add. I mostly agree. The thoughts that came to mind is, these devices that don't differentiate, can allow possibly like quicker access to care to the vast majority of patients with sleep-related breathing disorder, right? Because the vast majority of them are going to be obstructive sleep apnea.
Right.
But then we shouldn't then just kind of give them auto CPAP and let them go, right? Like it underscores the importance of follow up, making sure that they're actually doing well, that their downloads look okay, and having a very low threshold to look further if it's not going the way we think, plain old obstructive sleep apnea is supposed to go. So, if they're not doing better, if their residual AHI is elevated, then just kind of err on the side of getting a PSG and a titration study before escalating to other types of therapies, right?
Thank you all for joining us today and helping us to better understand how to implement these new central sleep apnea treatment guidelines into our clinical practices.
Thank you, Seema.
Thank you, Seema. This was amazing.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.